بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين وخاتم النبيين ورحمة الله العالمين سيدنا محمد وعلى آله وصحبه أجمعين. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا إنك غفر لنا وللحاضرين. السلام عليكم ورحمة الله وبركاته. Good day everybody. This is me, Dr. Ibrahim Halawani. Today, inshallah, we should resume our journey with cardiac anesthesia notes. Last time we finished the general aspect about the preoperative management as a skeleton or as a whole, starting from uh, preoperative assessment, intraoperative management, and most of the things that are shared between all the cardiac surgeries. Today, inshallah, we will start in part two or volume two, which is we will speak individually about each type of surgery, and we will go through the same skeletons that we expand upon in previous sections, and we will highlight what is important about each type of uh, different surgeons. Today, inshallah, we will speak about the CABG. Sometimes they call it revascularization. Some centers call it the bypass. Okay, so let's start. Bismillah, tawakkalna ala Allah. Early in 1960, they started the first CABG. They done it through median sternotomy. Uh, they used cardiopulmonary bypass and they use internal mammary artery as a conduit, and the surgery was on beating heart. So the idea is this is the aorta. From the aorta goes the coronary arteries. If you have some sort of a block inside this coronary artery, what you aim for is a bypass, that you either get another artery to bypass this obstruction, like the lima or left internal mammary artery, or you get a venous graft, put it here on the aorta, connect it to the aorta, and put it after the obstruction, which we call it the venous graft. And this conduit can be a venous graft or can be arterial graft, and we will be speaking about it again. But when we're speaking about our historical uh, view, when they got or they able to do better cardiopulmonary bypass technology, and we will able to have a good results with the cardioplegia, this allowed the surgeon to go on bypass correction. At this time, he can go to the posterior wall of the heart and complex more complex anatomy he can do. Then off-bump cabbage, or they call it op-cab, it revolved again, still use the median sternotomy, but try to avoid the cardiopulmonary bypass. And it said that it has some good patient or some patient will get benefit from it, which is usually the patient who will have a huge risk of the cardiopulmonary bypass or poor cardiac function. And so far, the results between both, which is better, is it the cardio on bypass or off bypass? And a lot of debate since the 90s about both. And the final said, or the final decision that whatever will you masterize, you should do. Because they found a lot of bias in the type of evidence. Like, for example, they said that this surgeon or the results of bamboo was bad, but they realized that it was bad because the surgeon who had done it was in the learning curve. That's why the outcome was poor. While if a surgeon is specialized in the off bump and they limit the sample to a surgeon to who has, they said, at least 200 cases of off bump before they see his results, and an annual cases. They put some parameters before enrolling the cases of surgeon, and finally they found that there is no huge difference between on bypass and off bump. But the most important is the familiarity and the education level of the surgeon. Of course, some patient we cannot put a bypass, we cannot put cross clamp or stuff like this. These are the patients that it's by anatomy or by indication he's indicated for op cap. As you see, he's repeatedly said median sternotomy because now we have what we call minimally invasive, which are any surgery that does not involve median sternotomy. They can do thoracotomy, they can do both, whatever the technique, but it's this one. We can call it open heart surgery, anyone with sternotomy, and anything other than sternotomy, we'll call it minimally invasive. Anything we will avoid the bypass, we call it the off bump. Anything we did not avoid, it's the normal one, which is the normal or the standard open heart surgery. Just to be familiar with the names. Then, of course, we will speak a little bit about CABG from the perspective of the surgeon or the cardiologist. Then we will speak about it from our scope as anesthetist. We need to be familiar or we need to be updated with some issues regarding the CABG, like is it effective? يعني, is it a good therapeutic option? They found all the studies that CABG in multi-vessel disease, there is a significant reduction in the mortality, regardless, as I told you, the method use. Whatever, minimally invasive or standard open with bypass, or standard sternotomy with bypass, or sternotomy of pump, or minimally invasive with bypass, or minimally invasive without bypass, whatever. All of these, any multi-vessel disease, usually CABG cause a significant decrease in mortality and long-term survival between CABG to BCI in patients which are intermittent and high risk, sorry, complex. And this is very important. Complex patient that they have, as we're gonna say, multiple obstruction at many levels or stuff like this, the long-term survival with CABG in such patient is better than BCI. And also, CABG has fewer MI and fewer repeated revascularization in these high-risk patients. Okay, so now you in your mind, I want you to know that CABG is usually for complex patients, complex complex ischemic patient. Okay, he's superior to BCI. Okay, what else? Okay, let's go a little bit about the coronary anatomy and some physiology, just to torture you as much as I can. Usually, we have two main coronary arteries. Okay, they arise from sinuses of Valsalva, located just behind the aortic cuff. Physiological, usually, you must be no, you must be familiar with the coronary blood flow. A lot of MCQs will come in this regard, either even in the general side. They like resting, how much is 25 mils per minute. It's usually 5% of the cardiac output. Most coronaries during diastole. Okay, myocardial resting oxygen myocardial consumption is 10 milli per kg, sorry, per milligram per minute, represent 10% of the total body consumption. Oh, heart increase the oxygen supply by increasing the blood flow, not oxygen extraction. If you remember when we spoke about oxygen extraction, okay, when we spoke about in the monitoring, when we speak about the mixed venous, and we said if patient is septic or hyperthyroidism, he is increasing the extraction. But the heart is not doing like this. If the heart needs more oxygen, that means he need more flow. And that's why we care a lot about the blood flow of the coronaries. So key point summary. Coronaries are the first branches of the aorta. Coronaries perfusion is during diastole. High oxygen demand, limited ability to increase oxygen extraction. Supply, increase flow, increase flow, increase flow. Okay. Now let me show you uh, something about the anatomy. Just 1 second. Bear with me. Now this is the heart. Okay. If you are, this is you as anesthetist, and this is your anesthesia machine. Usually, this is the upper part of the heart that you will see. If we tilt it a little bit to demonstrate, this is the aorta. Okay, as you see, it's coming. Then we have this nominate that it will give the subclavian and the sorry, it will give the common carotid and subclavian. This is the left common carotid, and this is the left subclavian. Don't bother yourself. But here, this from here, we will remove this part to see. Sorry. As you see, from here is the beginning of the aorta. This is the aortic valve here. Obviously, up from the LV. Okay, the aorta is coming here. You have these three cusps, 123, and from here, as you see, this is the orifice of the right coronary artery. Okay, so I will show it to you in here. If we put it like this, okay, I will open it slowly. See, okay. So this part here, ah, this is the right coronary. It goes like this. You see. Then it's going here from the aorta to below the auricle. Then it's passing here in this groove. Okay, and going all the way to give sometimes the posterior descending artery, the red one. Okay, is it clear? You still see me or an interruption? Clear so far?
Yes, boss. Yes.
Okay, fine. So the right coronary arises from the anterior aorta. As you see, here is the anterior, here is the inferior, and this is the right of the patient. Usually the surgeon will stand here. Okay, you will stand here. Okay, and this is the left of the patient. Okay, so the right is from here, from the upper part, from the anterior part. See here, I hope it's clear. From the upper part of the aorta. Okay, and that's why if we have deaeration, usually this is the upper part of the aorta, so any air, it's easy to come from here. Okay, it gives acute marginal branch, this one. Okay, and in 85% of patient or population, it will give the posterior PDA. Okay, as you see here, it's supplying this part, which is the, if you take it out, supplies the right ventricle. Okay, and the posterior wall of the right atrium. Oh, sorry, the right ventricle. Sorry, the left ventricle. Posterior wall of the left ventricle. Usually, SA, usually here we have the SA node is high here, so the artery here gave to the SA node. I'm not sure is it. Let's remove this one. The artery here gave to the SA node also, and also gave to the AV node, which will be situated here. This is the triangle of Koch. The AV node will be here. So this artery, the right artery, it gives marginal, it gives the SA node, it gives the SA node, it gives most of the right ventricle, and give part of the posterior aspect of the left ventricle. Okay. And as we said, because it's anterior here, it's more prone to air. So clear so far? Then we have the left side coronary. If we gonna see it, it will be, he's putting it here like this from here. Okay, of course it's not like this, yani, but yani, imagine it with me. It will come from the left side of the aorta and just go here to give two branches. Okay, the LAD, which is this one, this is the RV. Okay, and this is the LV, and this is the groove. So the LAD is going here, left anterior descending. It gives septal branch, if we remove it like this, you will find that it's over the septum. So it gives the septal branches from here down inside, okay? And the anterior wall of the LV, this part, and of course, part of the conductive system, the part that running inside the septum, okay? Then his brother is the CX, that's the one that gonna rotate from the auricle here, this one, no, sorry, okay? Usually, it supplies the posterior aspect. Usually, it gives the what we call it the OM, the obtuse marginal. This one, I think. Yes, this is the one. And either it will give the BDA. Again, let me. Either it will go to give the BDA in 15% of patients, so it will be left side dominant, or the BDA, as we said, come from the right side in 85% of persons. Okay. So again, the right is arised from the anterior here. That's why it's more prone to air. It goes to give the SA node, to give the AV node, to give acute margina, then go posterior, and then the posterior it gives the posterior BDA in 85% of patient or population. Then the left side, it comes the left main, then gives the LAD. The LAD is running here over the septum, gives the anterior aspect of the left atria, left ventricle, also give branches that goes down in the septum, septal branches, and his brother is the CX that will go all through like this, gives the obtuse marginal, and either it will give the BDA in 15% of patient of population, or as we said, it will be the right. Okay, so as we saw and as we said, right coronary artery arise from the anterior aorta, prone to air, gives acute marginal. Acute marginal is different from the OM. The OM is obtused marginal. OM is obtused marginal. This comes from the CX. Two letters, two letters. Okay. In 85%, it will give the BDA. Okay. As we said, it's giving supply to the RV, to the posterior wall of the LV, AV node, and SA node. Left coronaries, we have the left coronary artery, or we call it the left main. The left main will give the LAD CX 15%. Left dominant CX will continue as the BDA. Okay. LAD give septal perforates وdiag. So LAD, it will give SEP and DIG. Septal branches, diagonal branches. When you see this abbreviation, keep it in your mind. Okay. And as we said, it give septum, LV, okay, papillary muscle, part of the conduction system. When you remember when we said that we have two papillary muscle, we said one have two supply. I think this was in the echo. So TX, posterior interventricular BDA in the left population, and as we said, it gives CX, it gives the OM. Okay, this is the anatomy and the part of the physiology. Also, this is a huge, uninteresting part in the physiology of the coronaries and the ischemia. Oxygen content. What is determined of the oxygen supply? If you want to increase the oxygen supply of the myocardium, how you gonna do it? Oxygen content. Content we said 1.3 by hemoglobin by saturation and 0.003 multiplied by AO2. So now if you have a good BO2 and the saturation is fine and the hemoglobin is good, it will improve the content of the oxygen. Coronary, we said that this is the most important one. Heart rate, higher heart rate means less diastole and less time for the perfusion. And as we said, perfusion, flow is very, very important for the oxygen supply of the myocardium. Coronary perfusion is the difference between diastolic pressure and the LV and the diastolic pressure. If this is the LV, inside the LV in the diastole, there is blood. This blood has the diastolic pressure inside the LV. LV in the diastolic pressure, and the other part of these vessels, it has the diastolic pressure of the systematic in the aorta. So the difference between the aortic diastolic pressure and LV end diastolic pressure is the pressure of perfusion of the coronary. Okay, I will not speak about, but it's easier. Keep the diastole high, keep LVDP pressure low, lower the heart rate. It will be better. LVR resistance. Okay, so what can cause increase? You remember when we say pulmonary vascular resistance and systemic vascular resistance, we have also coronary vascular resistance. But mostly it's more important for the cardiologists. They are taking care about this one because sometimes they want to know if their coronary is in a spasm or not, or if the coronary will improve, if they dilate, it will be good or not. So, what is the factors that affect the resistance of the coronary blood flow? Metabolic, like hypoxia, CO2, lactate, all this stuff. Adenosine is a potent vasodilator. Okay. Autonomic, الالفا cause vasoconstriction, البيتا vasodilatation. Autonomic as a whole is less. Angiotensin 2, vasopressin, both vasoconstrictor. Mild vasodilatation من البراديكاينين, NBVI, GGR. All of these are uh, substance that they are using during the cast, okay, or the BCI. Endothelium vasodilators like nitric oxide, prostacyclin, bradykinin, vasoconstrictor, endothylline, thromboxane, anatomical factors, all of these. The one I want to highlight is the coronary stenosis. Why? Because it's restricting the flow at more than 80% diameter stenosis. And the flow is decreasing by diameter to the power of 4. So 50% means that the flow will go to 1 over 160. And this is very important, that the coronary stenosis is a huge uh, determiner or a huge factor in affecting the coronaries. Okay, I will leave all the others to read. It's better you to read and to be familiar with all these factors because sometimes it came in the MCQs. This is the supply. What will increase the demand? As we said, heart rate, because it increase the demand and decrease the diastolic function. Okay, contractility increase the oxygen consumption. Wall stress, I don't want to go through it, but they call it the loi de Laplace or Laplace law, that the more pressure and the more afterload, the more oxygen demand. Okay, if the heart is more dilated, it also will cause more at certain level. It will be a problem. Also, wall thickness, inverse relation, but it also can cause increase in the oxygen demand. Simply speaking, I don't want to go to a lot of details about this one. The summary, the most critical clinical part for us is the heart rate because it impacts both the oxygen demand, it will increase the demand, and the supply, it will decrease the diastolic time. Understanding the dynamic relation between flow, contractility or tension, all this stuff is essential to prevent ischemia. Okay. Another thing I want to also to be familiar with how to read the angio report. Okay, I show you already the anatomy of the coronaries. Then usually you said that this is a stenosis 50%, 45%, 30%. All of these things you will see it, okay? But usually even up to يعني 45%, there is no huge affection on the coronary blood flow. And also, it's not only the stenosis that affects, the absolute diameter of the vessel is also important. How long is this vessel? Okay. How long is the stenotic part? Okay. How the exit, the angle. If the stenosis on an angle, it's very problematic because it's It's not easy to dilate. If you dilate it at an angle, it could close the other one. And sometimes the lesion is irregular. Even it could be small, but the shape of the stenosis and the shape of the vessel is also important. Okay, and also there is a poor correlation between the percentage of stenosis in the angio and the actual physiological impact on blood flow. يعني sometimes you see a patient with significant LA, okay, and he's telling you, no, I don't have any chest pain, I can go and come and no problem. Okay, so always keep in mind these parameters, hemodynamics with coronary stenosis. As the coronary stenosis progresses, coronary vascular reserve is declined. When the stenosis exceeds 50%, here the internal diameter resistance will increase exponentially. يعني even a slight increase in the stenosis more than 50% is very important. Usually we say it's significant when it's more than 50%. Okay, and 70% diameter correspond to more than 90% reduction in the area. And usually we have two type of patients: the stable exertion angina, that's the patient telling you that يعني only I have angina when I have exertion, otherwise I'm stable. This is usually an uncomplicated lesion causing more than 75% stenosis. While stable angina, the patients that have pain anytime, mostly it's more than 90% stenosis. And also this unstable angina patient, usually their native, after the CABG, they depend on the CABG vessels that the surgeon bought for them because the natives is not sufficient. Okay. In anything so far, I know it's a little bit away from our anesthesia scope, but you need to be familiar with your patient. Okay. The indication mainly for CABG is either to improve survival or to improve the symptoms. Usually we have emergency or acute indication when they failed in the BCI, okay, or acute ongoing ischemia, cardiogenic shock, everything we tried, or patient have additional valve, so it's better to go, or mechanical complication, okay. Sometimes we have a redo CABG, okay, but mortality here is higher. And of course, we all the problems with the redo, we know it, and we will speak about it. Type. Another thing you need to be familiar with, what is the conduit? What are the grafts the surgeon use? Usually, the most common one is the create saphenous vein. Usually, they use the vein. Why? It's readily available, easy to harvest, shorter patency to arterial. And arterial will be patent for longer time. When they take it either the side or either the leg. They prefer the leg because the size down is bigger or matches well with the coronaries, okay, and the same patency. So they can take from bilateral the legs. Then we have a huge one. Now they can open it, and nowadays they start to do endoscopic to decrease the infection and the problem with the wound. The second one is Lima or the internal thoracic. Excellent طبعا, and strong resistance to atherosclerosis. Usually, we have two types of Lima. One is called skeletonized, which is they take only the veins. They remove all the fascia or the tissue around it. So only the artery you have, and usually it's longer, increase longer and improve the sternal vascularity, would decrease the sensory deficit, will avoid the complication. Usually it's more technically difficult. يعني not everybody can do it. Most of the time they do it non-skeletonized, okay? The right one, we can use it for the right side, but usually we cannot use it for the CX or the BDA. And bilateral is good sometimes, but it can have, يعني they can take the right and the left, coronal, Lima and Rima, but can cause a problem, especially in elderly and obese, diabetic, all this stuff. Radial, muscular arterial conduit, يعني you need to assess first the ulnar, and usually it's a good patency, but a good thing that or something to keep in mind, usually we start for M calcium channel blocker like deltiazem in the ICU. Another one, maybe most of you will not be familiar, is the right gastroepiploic artery. This list commonly used now, but they are using for the inferior wall, and it's very difficult to harvest. I'll show you here. It comes from the abdomen, okay, and they pass it through the corona, the diaphragm, and they put it to the inferior wall of the heart. Okay, so usually they do care about the length and diameter of the conduit and the vessels resistant to atherosclerosis. Arterial is better, long-term patency, survival better, recurrent is recurrence is less, and fewer reopening. Typically, usually they use the lima to the LED and venous grafts, usually for other territories. Full arterial revascularization in younger patient and longer life expectancy. And if you have a patient in the 20s, 30s or something, usually they harvest the radial. They try to take the RIMA for the LED, take the LIMA to the CX or the BDA, and they take the radial to do additional one to the right coronary artery or to the right side. This says that full arterial revascularization is better. Okay. Now our part as anesthetist, preoperative or perioperative management. Those who attend with me before, we used to say we have preoperative history, demographic, the cardiac assessment, 3A, DCR, chest, blood, GI, then examination of the vital, local is the airway, local line way, we head to toe examination, and the investigation directed by history and the examination. Then you recheck the patient, additional local examination, BBC is bed, blood, and consent in the holding area. Then in the OR, prepare your OR instrumentation. Make sure that all instrumentation is available, drugs, anesthetic drugs, and cardiac drugs. Pre-induction, what monitoring you will use, and baseline vitals. Then induction, intubation lines, drabbing, skin incision, sternotomy, harvesting, heparinization, cannulation, on bypass, weaning of bypass, post bypass, we do hemostasis, closure. If it is fast track, is suitable for on-table extubation or transfuse to ACICU and handover. Type. If we go now for our patient, of course, it's very important to assess the risk factors and optimize any modifiable condition. Same thing, we go to the history, demographic data of the patient, cardiac, everything the same way. But some things we need to highlight, make sure anemia, it's a modifiable risk factor. It's better to improve anemia before going bypass, before going for surgery. Hyperglycemia, if patient has higher hemoglobin A1C more than 8, usually he has higher risk for MACE, tobacco cessation will decrease the complication. And also there is some evidence that it enhances the venous graft patency. Okay. Hypertension also, yani, try to control it before we go on surgery. Beta blocker. See, we have two types of patient. Patient who already on beta blocker, continue it, and the patient who did not start beta blocker. Should we start it or not? So far, it's yani, there is no consensus about it. Some patients, they found them did not get any benefit from it. On the contrary, they has more problems. Okay. Then now you take preoperative assessment of your patient, preoperative briefing, discuss with the surgical team. Will it be on pump? Will it be off pump? This is important. Use of aortic cross clamp or not? Yani, is it on pump or on? Graft type. Will he need the radial? Because if he needs the radial, you need to spare it from the A line. Okay. Will he use venous or not? Special risk. Any other a problem? Aortic regurg, ascending plaque. We will need a standby aortic balloon. Should we start it from the beginning? All these. Now, patient in your holding area, recheck the patient, recheck your plan, additional local examination. We said local for the airway, local for the lineway, okay, BBC, blood consent, and bed, most of it. Now in the OR, prepare your OR. Okay. Common problems with challenging, we will see patient who will have hypotension sometimes or hypertension. Just keep it in your mind. Target. Usually we keep a map of 65 to 80, but if the patient is hypertensive, usually we aim for higher map. Okay. Control the hypertension in the time of hypertension. Okay. Especially when they cannulate the aorta and this stuff. What drugs you should be available with you? Inotropes, ephedrine, epinephrine, Dobio, okay, vasoconstrictors like noradrenaline and vasopressin, vasodilator like nitroglycerin, GTM. Clinically, extreme vigilance, rapid diagnosis intervention, all of these, and the prevention of myocardial ischemia. All of these are the problems or the main items will be in your head while you preparing your patient in the OR. Pre-induction, you will put monitoring, 5-lead ECG, continuous multi-lead ECG monitoring remains the cornerstone of intraoperative ischemia detection in CABG patient. Safe, inexpensive, easy to interpret, continuous, and can be automated. يعني nothing else you will need. Okay. ECG changes occurs later in ischemic cascade, especially if we have mild coronary mismatch and during off pump. ECG show real-time ischemia improvement upon reperfusion. Okay. ST analysis. This is very important. Depression means endocardial ischemia. Elevation, transmural, mural, the whole wall. ST changes occur 60 to 120 seconds after ischemia onset. A reference point 80 milliseconds after the G point. When you say there is significant either ST elevation or ST depression, when it is more than 1 meter elevation or depression in two contiguous leads. Usually we are doing it automated ST analysis. It's in your monitor. The monitor will measure it for you, but all you need is to keep your eye on it. Okay? Keep your eye on the ST segment analysis. This is the message I wanted to deliver today. يعني what بقى if you have a ST changes? It could be ischemia, pericarditis, a problem with the ventricle, a problem with the lead, or a problem with the filter. Okay, so if you have an ST problem and you don't have something also with it, يعني try to make sure that the lead is fine and the monitor is fine before conclusion. Okay, T wave, inverted T wave, possible ischemia, not always accompanied by ST changes. Multi-lead, use inferior 2, 3, or AFF. Usually we are using 2 and the anterior V5 because those together detect 90% of the ischemia. Posterior ischemia is poorly detected with the standard EEG. It's not for us. And modified chest lead, you sometimes need to modify where you put the lead so to avoid the interference with the surgeon. Okay, ECG is very important. That's why I said, and I keep on saying it every time. External defib in all patients, and especially if patient you cannot do open, like patient in minimally invasive, redo whatever. All of these patients and myself, I believe it's in all cardiac patients. Pulse oximeter and the nurse. Invasive, you should put A line, and as I told you, you should see if you're gonna put aortic balloons or you're gonna go on bypass before. All of this you should discuss with the surgeon to know where you're gonna put your A line, and I think we spoke about it in the monitoring. Then temperature, we will be speaking about in a minute. Once everything on place, take ABG, know your baseline saturation and baseline nerves, and the baseline ACT. Patient now is ready for induction. I took an opportunity here to speak a little bit about the pharmacology of our anesthetic drugs. Propofol, use it in the induction maintenance. It's the main thing we know that decrease the SVR, we decrease the oxygen consumption, we decrease the coronary blood flow, and the mild decrease in contractility. Usually, if you give propofol, and this is something you should know, to avoid this one, slow or infusion, this will tackle this problem. Yani if you give slow incremental doses of propofol, like for example 10 milligram every half minute, This will not affect the systemic vascular resistance. Or if you calculated the dose and you use it as an infusion, also it will not affect this SVR significantly. You can also add small dose of ketamine. They call it ketofol, like 0.25 milligram per kg. This one also can help with this decrease. And the other thing, you can give a small dose of phenylephrine. Okay, you can give it also. All of these scenarios can help you with the hypotension that occurs with the decreased HVR with propofol. Ketamine, oh, most of you know all ketamine. Usually we are using it in a low dose. Okay, either 0.25 up to zero point 0.5 mic per kg kg as a bolus or as an infusion. It preserves blood pressure and help you intimidate. Everybody knows intimidate and how it's stable heart rate and cardiac output and everything. Yeah, the problem is usually it has some sort of what we call it emergency phenomena. Patient will go do some abnormal movement and also suppress the cortisol for more than 20, less than 24 hours, but no increase in vasopressor need. Benzodiazepine. Now they are speaking about try to limit the dose to of benzodiazepine to around 4 milligram in the total surgery. Otherwise, it can give negative inotropic effect and hemodynamic instability and delayed emergency and increased delirium. Usually, our protocol is used as incremental of zero point 0.5 milligram boluses and follows the response, not to go to higher doses because now it's avoided in the modern practice. Clonidine and dexmedetomidine, they can also be used. The volatile agents, most of them can cause depression in the SVR and contractility. Heart rate, isoflurane slightly increase heart rate in low doses, and the high doses, it can decrease the heart rate. This fluorine is almost like isoflurane also. Contractility, mild decrease in contractility, especially if you increase it. After load, decrease some decrease in the SVR, especially also in high dose, and can cause some peripheral vasodilatation. Coronary steal phenomena. This is something that they found it in the 90s, as I can remember, or early 2000s. They said with the isoflurane in canine models, but no significant in our clinical practice. The precondition, this also and you start to gain some attention that it could you can start the eyes you can start the volatile before you go 10 minutes before removal of the cross clamp. They said it have a good preconditioned effect, but so far still we يعني no huge data multi-centered arts to find that there is a huge difference. Yeah. Opioid, most opioid decrease the heart rate, especially except Bethadine, okay, which we don't use in cardiac. Contractility in clinical doses, minimal effect. And I am highlighting here clinical doses because high doses can cause uh, depression of the contractility. After load, and now even the trend now is to use lower clinical doses. Don't go for high doses like 25 mic per kg or 50 or 100. This used to be a high doses regimen. It's not used anymore. It affects hugely the contractility. After load, usually this decreases sympathetic tone, and the preload in moderate to high dose, it can decrease, like I said, from 25 mic per kg and up. Uses in cardiac surgery, high dose opioid used to blunt surgical sympathetic response, but modern, no, lesser dose now are used. Muscle relaxant, succinyl, the depolarizing, still used in emergency intubation, difficult airway scenario if you don't have rocuronium and high sugammadex. Of course, it has a problem like hypo hyperkalemia, myopathy, skeletal denervation. We are not using it. Malignant hyperthermia, but its usage in cardiac surgery is mainly in emergency intubation if you don't have rock and sugammadex. Rock now, يعني most of the time everybody's using it. It causes some histamine release, okay, some vagolytic effect, intermediate duration of action, and the reverse with sugammadex is excellent results now. Vicuronium is the brother of rocuronium. They call it because it was very cardiovascular stable, okay, and it can cause some bradycardia. But and since long time I didn't see it. So Cisatracorium now is the other family of the muscle relaxant, minimal cardiovascular effect, Hoffman degradation, elimination, easy hydrolysis. Usually they prefer it in renal patients. يعني it has an upper hand in patients with renal. Actually, now there are some controversy about whether it's good to use Sogamadex with rocuronium or vicuronium, okay, in renal patient, or it is better to use neostigmine with something like cisatracorium. And we are still waiting what they're gonna decide again. Okay. Now we decided what we give, and the patient sleep. You put the tube. After intubation, you put the CVL with or without pulmonary artery catheter. We spoke about this before. Just rapid refreshment. It allow what we're gonna use it. Usually, it could offer the advanced it can offer to help you calculate cardiac output, pressure monitoring, temperature, continuous mixed venous cardiac output, as we said. And of course, now with the use of TE, it's a little not used like before, but remains valuable in the ICU management. So now we are mainly using it if the patient has low cardiac function and pulmonary hypertension, okay, and prolonged, I don't know what prolonged cardiopulmonary is, but mostly we are using it for low function and pulmonary hypertension. As we said, usually they are using it for ischemia detection, which is new V in the pulmonary capillary wedge pressure. And I think we spoke about this too much before. T, we once we put the lines, you return the patient in normal position. Okay. Tie TE temperature probe. Tie the tube, put the transesophageal echo. Why we need it in CABG? It will confirm the central line. It helps to assess preload. It helps assess the contractility, detect re- segmental regional wall motion abnormality, detect aortic cannulation site, detect valve pathology, detect precardial effusion, detect if there is effusion and it has it any hemodynamic impact, aid in the position of the aortic balloon, aid in the position of the coronary sinus catheter, detect ventricular aneurysm, detect if there is septal defect. Most beneficial in patients with decreased cardiac function or unstable hemodynamics. Less utility in stable patient with normal transthoracic. Okay, so as you see, mashallah, it's helping in almost everything. And as we say, detection of resting wall motion abnormality, just something. What's the limitation? Tethering. Non-ischemic segment may appear abnormal during two mechanical linkage. Tethering is like some parts of the it's not ischemia, but there is a problem with the chordae itself. That's why it makes some areas of the heart move abnormality. And basing, this is the one I want you to know. Basing, it will alter the wall motion. Okay, if you are post bypass and you find abnormal motion, that might be because of the uh, basing. Stunned myocardium, diastolic pattern, all of this, not interesting. Infarction complication detection, as we said, sometimes acute MR or you have a VSD or effusion, global dysfunction, all of this can occur with the infarction. You can see it with the TE. Okay, TE is in everything, time out. Now they will prep. DRAPE is a time of low surgical stress. Patient prone to hypotension. Take care. Then this time, most of the problem occur in this time because at this time you try to relax and you sit. Patient begin to get hypotensive. Okay, if the patient is already hypertensive and his coronaries used to have high mean pressure, it's dropped. There is a problem. Skin incision, it's a high stress, hypertension. You will give boluses of drugs. Sternotomy, same, and you need to disconnect the lung. Harvesting, this is a long time of low stress, also prone to hypotension. Keep on. Then heparin. Is it on pump or off pump? On pump, a high level, we give heparin 300 to 400 and the ACT more than 148, 408. Type. If it is off pump, heparin low dose 100 to 200 and the ACT 250 to 300 only. And of course, if patient is had, bivalirudin will be better. خلاص, heparin is safe. They harvest. After they harvest the veins and the artery, you will give the heparin. Okay, you give the heparin. Heparin is safe. They cannulate and they go on pump. As we said, either on pump or off pump. Off pump requires stabilization of the coronary artery, lifting manipulation of the heart. So it's a little bit demanding. You need to have a vasoactive infusion like noradrenaline, phenyl, vasopressin, and good volume. Okay, because there will be a lot of manipulation during the uh, off pump. The other thing, temperature. Why I mentioned temperature alone? Because usually the standard we know it's important. Why? Hypothermia can cause arrhythmia, coagulation, shivering. This shivering increase oxygen demand and delay metabolism. Okay. Usually we recommend we measure from the nasopharynx and the bladder. Okay. Rewarming in the on bypass and all this stuff we spoke about it before. But what I am highlighting here off bump, usually the patient easily get hypothermia because his whole chest is open for the whole surgery. He's not going on bypass, so he's not having the heat exchanger that we are doing on bypass. Okay, so in this time you must also be vigilant in the off-pump cases to use forced air warming, okay, and maintain warm OR environment. Take care because usually the heat loss is high and unanticipated. We done. They are do weaning. Then post cardiopulmonary bypass will do hemostasis, will do the closure, and if the patient is for fast track, we will extubate or send him to the ICU and hand over. That's all for today. I hope you find it amusing. جزاكم الله خيرا. السلام عليكم ورحمة الله وبركاته.